Hello and welcome to the HFA Studio by ESC TV. My name is Ferran Sahiti from University Hospital Würzburg in Germany, and I'm also a member of the Young HFA community. It is a great pleasure to moderate this session together with the winners of the 2026 Investigator Award. Today we will speak with three outstanding investigators representing three important areas of heart failure research and care, namely basic science, clinical cardiology, and nursing and allied professions. I'm delighted to welcome Dr. Frits Damian from Groningen, the Netherlands, Dr. William Becker from University of Connecticut in USA, and Mr. Amir Wahab from McGill University in Montreal, Canada. This session is especially meaningful from a young HFA perspective because it highlights creativity, ambition, scientific quality of the next generation of heart failure researchers. First of all, congratulations, all three of you, on receiving the 2026 Investigator Award. Let us begin our talk with the first award winner. Our first speaker represents basic science, Dr. Frits Damian, which presented the work with the title Phosphoproteomics Distinguished Disease-Specific Mechanisms for Human Phospholambda Cardiomyopathy Reversible by RNA Therapy. Dr. Damian, welcome and congratulations on winning the prize. My first question for you is, what was the main question or observation that inspired your work?
Thank you very much. So in our hospital, we have a big problem, and that is called phospholambda cardiomyopathy. And it's a pathogenic variant that can cause heart failure. And we have a very high prevalence of this pathogenic variant in our hospital. And as of current, we know that there's no specific heart therapies available for this etiology. And that's where we come in, because we wanted to help treat these patients. Because as of current, standard heart failure treatment is not sufficient for these patients. They become sicker and sicker until they eventually need either a heart transplant or an LVAD implantation. And we want to be able to treat these patients better so we can keep their quality of life higher.
Interestingly, and what were the main findings of your work? Can you share it with us?
We are working on RNA therapy as a treatment for genetic heart failure. And what we show in our work is that we designed an ASO that is capable of downregulating the mutant, the phospholambda mRNA in our cells. And we show that the key pathogenic driver is suggested by our data, which is the protein aggregation, is reduced after the treatment with our RNA therapy. And we also characterize it further. We also looked at disease phosphorylation, and it implicated that cytoskeletal remodeling is proposed as the therapeutic axis of our RNA therapy. And we hope that in the future, this RNA therapy could help patients to improve their outcomes.
Do we have already long-term data on this therapy at this moment?
We're working on it currently right now. So based on my work, we started a phase 1 clinical trial called the PULSE study. We're currently recruiting PLN R14del carriers in the Netherlands, and we're treating them to see its first phase trial. So we're first focusing on dosage and on safety. And based on this phase 1 trial, we will decide whether indeed we can go through with this treatment and move towards a phase 2. But the long-term safety data will be derived from these upcoming trials, which are going to be very exciting.
Really interesting. Thank you very much for your work. And what would be your take-home message to the listeners and to our viewers with regards to your work?
Our take-home message would be that if you have a problem in your cell, there's too much of something that causes disease, then you can tailor RNA therapy to downregulate your disease-causing pathway. In our setting, it was phospholambda, which was a mutant protein that aggregates in the cell and causes the cardiomyocytes to pass away. And this causes cardiac fibrosis and a decreased cardiac function. But we can show that with our RNA therapy, we can downregulate this problem-causing mRNA, and in this way treat the cardiomyocytes so they will no longer have this protein aggregation, which will hopefully translate to the patient setting as well, because we know that the PLM protein aggregation is present in these patients as well. And we think that this is the main pathogenic driver that causes the disease.
Interesting. Thank you very much for your work. Looking forward in the future to see results of the next projects and next follow-up studies. We move on to the next award winner, namely Clinical Cardiology, where Mr. Amir Wahab from Montreal, Canada, presented his work with title Inflammatory and Adipokine Associated Proteomic Signatures of Heart Failure Progression by Body Mass Index, Insights from the Examine Trial. Mr. Wahab, welcome to our studio. Can you tell us what was the main question or observation that inspired, in this case, your work?
Yeah, of course. Thank you so much for having me. I guess the main observation is that I think we've seen that heart failure can look and behave very differently depending on the type of patient that it affects. So I think that's sort of the main motivation is essentially to try to understand the heterogeneity that obesity can cause in the underlying biology of heart failure. And I think it's important because it helps us to better understand how we assess risk and then also hopefully to identify any unmet clinical needs that can be addressed through therapeutic intervention.
Thank you very much. And can you share the key findings of your work with the heart failure community?
Of course. So I think the results from the study essentially are showing that obesity seems to modify the underlying biology with heart failure, specifically by modifying processes like inflammation and adipokine signaling. So I think, again, that might represent something that we have not yet fully understood and don't necessarily target with available therapies. So it might be something interesting to look into about how targeting these processes could improve outcomes for patients.
So the next step in the research would be targeted therapy with,
Yeah.
with regards also to the obesity.
Absolutely. I think it'd be important to see a more causative relationship between these processes and heart failure progression. And a lot of that work is already being undertaken, and a lot of that work was presented at the Congress. So it's very interesting. It's very encouraging. I think we've seen that like modifying adipokine signaling can have some effects in these types of patients. So I think that would be the next steps.
Interesting. Thank you very much. Shortly for us, what would be your take-home message from the work that?
Sure. I think the most important thing is to just sort of understand that obesity can modify the underlying biology and that can influence how we assess risk, how we think of treating comorbidities in patients, and how we might develop new therapies for patients to address this unmet need.
Thank you very much. So we move on to our next award winner, namely our third speaker representing nursing, an allied session, a field that is central to patient management, education in this case, and also self-management. Dr. Becker presented his work with regards to phenotypic clustering to identify high-risk adults undergoing cardiac transplantation. Thank you for being with us today. Can you share with us what was the main question and observation that inspired your work?
Absolutely. Such a pleasure to be here. So we know that there's an ever increasing need for heart transplants in our adult populations across a variety of etiologies, but we're still not seeing an increasing number of donors. And because of that, triaging and prioritization of our available donors to the most needing recipients is really paramount. And there are a number of available risk tools that are out there available to identify who might be at highest risk of post-transplant mortality. But a lot of these are somewhat convoluted in some of the factors that go into them. Some of them may not use clinically apparent or readily available variables for them. And so we wanted to try to identify, is there a way we could use easier, more readily available information available to the clinician right at the bedside or in the office to identify or predict what their post-transplant mortality might be.
Interesting. This is a good approach for especially for the clinicians in this case. And what were the key findings of your work?
Sure. So what we did is we identified 5 clinical variables. We looked at body weight, we looked at race, we looked at gender, we looked at diabetes, and then whether they had an ischemic etiology to their heart failure. And then we stratified according to age, and using a machine learning algorithm, we identified 5 distinct clusters of individuals based on these factors. So each of these clusters had commonalities in their traits, such as the highest risk cluster, which had about an 11% one-year mortality risk, was generally made up of older white men who had diabetes and an ischemic heart failure etiology. Compare that with the lowest risk mortality risk cohort or cluster, which had a one-year mortality risk of about 7.5%, was primarily made of lighter women with very little or no diabetes and other non-ischemic heart failure etiologies. And so what we found is using these 5 very simple variables that clinicians can have right at the bedside. We don't need fancy calculators. We are able to identify clusters or groupings of patients that we can easily see are higher risk of post-transplant mortality or lower risk of post-transplant mortality. And we might be able to not necessarily prioritize an organ to each one of those, but rather maybe target the prioritization of strategies for risk mitigation and surveillance and things like that.
Thank you very much. Without going into details about the advantages and disadvantages of the cluster phenotyping,
Sure.
I would like to ask you, what would be the next step in this case? Are you planning in your center to apply these clustering phenotypes in a prospective study for your patients?
Well, I think there are 2 next steps. Now that we can see that using these very simple 5 variables stratified by age, we know that it works and that it is a viable way to identify or associate with post-transplant mortality. We want to integrate more advanced or some more sophisticated variables, things like did they have an LVAD, things like that. And then the third step or the next step would be to then compare that to the risk performance of some of our known and validated risk prediction tools to see not only is this clustering approach viable, but does it actually statistically perform as well as some of our known risk stratifying tools, such as an impact score, heart transplant risk score, things like that.
Amazing. Thank you very much. And a short take-home message for the audience, please, if it's possible.
Sure. I think that we can identify those individuals who are more likely at higher risk of post-transplant mortality, especially in older age, generally men versus women, generally of higher body weight, to go along with your paper, and then generally those that have diabetes and ischemic cardiomyopathies. Those that have certain combination of these are more likely to have a higher risk of post-transplant mortality, and we should probably be spending our time trying to risk mitigate those folks.
Thank you very much. So what we have heard today shows that the heart failure research across the full translational spectrum, from the fundamental mechanisms and disease biology to clinical decision making, and finally to patient-centered care and multidisciplinary management. I would like to congratulate our 2026 Investigator Awards winners again, and thank them for sharing not only the results but also the motivation about behind their work. And I would like to thank you for listening us and joining us today, and enjoy the rest of the Heart Failure 2026 here in Barcelona. Thank you.